Today, you're going to hear about an incredible drug development program for a novel anticoagulant. And there's three things I just want to mention briefly. Number one, team science. This program is a fantastic example of team science and will include over 20 Stanford faculty and staff to help run the program here and around the world. It's going to include cardiology specialists, neurology, primary care, emergency medicine, data sciences, and trial operational experts. The second is academic industry partnerships. This program highlights the potential for impactful, rigorous science through collaborations between academia and industry. And number three, mentorship and training. You're going to see today that the breadth and depth of Stanford's involvement in this program is going to provide great opportunities for our young faculty, our trainees, and our staff. So Marco, Nirali, and Brian, thank you for your leadership. Thank you for coming this morning, and welcome.
Great. Thanks so much for the introduction, Ken. And I'm going to go ahead and share my screen here. All right, so we're really excited this morning to talk a little bit about some of these novel strategies for anticoagulation in cardiovascular disease. So these are our relevant conflicts of interest. So the evolution of anticoagulation we've seen over the last 80 years or so has taken us from the use of heparin in the 1930s to now the use of direct oral anticoagulants for a variety of cardiovascular conditions. And what we've seen more recently is that these direct oral anticoagulants really are now preferred over warfarin. So at least for atrial fibrillation, there's now in the recent guidelines a class 1 indication of choosing direct oral anticoagulants over warfarin, and that's for a number of reasons. These DOACs are non-inferior, and some of them are actually superior to warfarin, and there is a favorable bleeding profile, so there's lower risk of major bleeding with these DOACs. But despite all of the benefits of these anticoagulant therapies, there's still a suboptimal use and adherence of these agents. And not only that, but even patients who are started on DOAC therapies, they have a rate of adherence that's not ideal. So about 15% of people who are started on a DOAC end up stopping it, and in great part because of the some of the side effects, which include things like bruising and bleeding. So this is in part because the DOACs and the anticoagulants that we've used in the past affect the common pathway that's downstream from the intrinsic pathway, which is responsible for pathologic thrombosis, but also the extrinsic pathway, which is responsible for vascular hemostasis. So in theory, ideally, we would be able to target only the intrinsic pathway. And one of the factors in that pathway is factor 11A. And that's potentially a target for anticoagulation without all of the bleeding risks that are associated with anticoagulants. And there are some clinical observations that demonstrate that this is feasible. In patients with congenital deficiency of factor 11A, we see that those patients, they tend not to have the arterial and venous thrombotic events, but also they rarely have major spontaneous bleeding events, unlike patients with other factor deficiencies. And similar observations have been made in knockout mice with factor 11 deficiencies. So currently, there are a few approaches in development for factor 11 inhibition, and these include antisense inhibition of factor 11, synthesis, and monoclonal antibodies for factor 11A. But these are all parenteral. There are, however, two oral small molecules, milvexian and asundexian, that are in development, which we're going to talk a lot more about milvexian today. There are several phase 2 studies of some of these inhibitors that have been studied in the setting of knee arthroplasty for DVT prophylaxis. And the important finding there is that the patients who have received these factor 11A inhibitors have very low rates of bleeding. Now, there was a phase 3 clinical trial with asundexian, which is the one of the small molecule factor 11A inhibitors, but that was stopped early, primarily for lack of efficacy. And this was a stroke prophylaxis in AF trial. And one of the thoughts is that it's very likely that the small molecule was just underdosed in that study. So the other small molecule in development is milvexian, and this is a potent inhibitor of factor 11A, and it has a very favorable drug profile. There was a phase 2 program that included 2 studies with milvexian, one for secondary stroke prevention and one for DVT prophylaxis after knee replacement. And that helped inform the phase 3 program, which we're calling Librexia. And what's quite unique here is that with unlike what was done with DOACs, in the DOAC trials, those trials were sequential, where one endpoint was studied and then subsequent endpoints were studied after that. In this phase 3 program, there are 3 large clinical trials that are being conducted simultaneously. So one for a stroke prophylaxis in atrial fibrillation, one for acute coronary syndrome, and one for secondary stroke prevention. So as Ken mentioned at the beginning, this is a very large program and it requires very large infrastructure. And importantly, there needs to be a lot of collaboration between industry developing this novel drug and academic research organizations. And so, the Stanford Center for Clinical Research is taking a leadership role here and is involved in much of the operations, a lot of the scientific development, clinical events, adjudication, biostatistics, and DEI efforts as well. And as Ken mentioned, there are several faculty members who have taken an active role in this program. And you're going to hear from Dr. Kim and Dr. Vora about the ACS and stroke Librexia studies. So the Librexia AF study that is being done has a very simple design. It's a 1-to-1 randomization scheme with milvexian being compared to apixaban. And the primary efficacy endpoint is a composite of stroke and systemic embolism, and that is designed in a non-inferiority manner. While at the same time, we are looking at primary safety endpoint of major bleeding, and that is being designed in a superiority manner. So we're hoping to see non-inferiority with apixaban, but superiority in terms of bleeding. The inclusion criteria is relatively straightforward. Not exactly a CHADS-VASc2, but for the most part, very similar. So age greater than 75, history of stroke, or 2 or more of the other risk factors. This program is already underway. It's an international program with a target of about 1,000 sites. And here at Stanford, Dr. Tina Bakener will be the site PI, and we're hoping to kick that off within the next month or 2. But you'll hear a little bit more about the Librexia AF program here at Stanford when the time comes. So with that, I'm going to hand this over to Dr. Vora to talk about stroke.
Thanks so much, Marco, and thanks to all of you in the Department of Medicine for including me. It's a privilege to be here among friends and colleagues. So I'm here to talk to you about stroke. As you know, stroke and cardiovascular disease make up the greatest burden of disability and death in the world. And did you know that 1 in 4 strokes are actually recurrent? Next slide. We do our best, right? All of us do our best on prevention. Next slide. And many of us are working on advocacy and policy avenues to think about social determinants of health to reduce the risk of recurrence. Next slide. But so much of what we do in stroke neurology also centers around understanding what is the best antithrombotic choice for prevention. So much of what we do lies on understanding what is the cause of a person's stroke, the stroke etiology, in order to determine whether we need to put this patient on antiplatelets or anticoagulation. In cardioembolic stroke, we all know we would start a patient on anticoagulation if they're found to have atrial fibrillation. Next slide. But 1 in 4 patients actually don't have an identified cause of stroke, despite an extensive workup. This is cryptogenic stroke or undetermined if you use the TOAST criteria. Next slide. And there's also a research paradigm called ESIS that you may have been hearing about. That's embolic stroke of undetermined source. This is when you've done a workup, you don't know the cause, or there's multiple causes of the stroke, and the patient's imaging for their stroke appears like infarcts in multiple vascular territories, suggesting that there was a proximal source for their emboli, or a wedge-shaped infarct, kind of like what you see on the MRI here. In the ESIS definition, patients had to have less than a 50% atherosclerotic stenosis in the carotid or large artery vessel that supplied the brain territory. And so that made up this definition for ESIS, and it raised the question that these patients probably have a high likelihood that the heart or something that's going to respond to anticoagulation is leading to their stroke, and they may benefit from this anticoagulation. And we asked the question, you know, on the flip side for stroke neurologists, well, we see a lot of bleeds too. We can't just empirically anticoagulate these patients. So next slide. The question of empiric anticoagulation for ESIS using DOACs versus aspirin was raised. And we actually have the answer to this question, that we should not empirically anticoagulate the patients. Patients with ESIS had 4 negative trials. The first 2, which you've probably heard about in the past years, are Navigate ESIS and Respect ESIS, which compared aspirin to rivaroxaban or dabigatran, respectively. And these trials were negative, largely due to no net benefit in ischemic protection. And in Navigate ESIS, the patients actually had higher bleeding. So next slide. One of the criticisms was that these trials were maybe too heterogeneous in who they included, you know, all ESIS patients. That was really broad. And so the next set of questions we asked was, could we enrich this population for patients who really may benefit more from anticoagulation, those with atrial cardiopathy, so structural or functional dysfunction of the atria, with the concept that sometimes patients with atrial cardiopathy might be having strokes independent of AFib, although parallel, and can also lead to AFib. So are we actually able to go a little bit upstream and pick out these patients earlier to reduce recurrence? Next slide. So the Arcadia trial was just completed, but we enrolled patients that had ESIS and then randomized them to therapeutic apixaban versus aspirin if they had one of these 3 biomarkers of atrial cardiopathy. So elevated BNP in the absence of heart failure, increased P-terminal wave force and lead V1, or an enlarged left atrial diameter index on echo. Next slide. And as I alluded to before, this was negative. This was actually just published last month in JAMA, and there was no difference in recurrent stroke risk between the anticoagulation and aspirin group. And bleeding was actually similar. Next slide. There was another small trial in Germany called Atticus that ended early. The contribution from this trial was that all patients had an implanted loop recorder, and that it also included as a biomarker for atrial cardiopathy and cardioembolism high rates of non-AFib atrial arrhythmias. But the study was small and also ended up not being superior to aspirin. So next slide. I think we know now that we can't anticoagulate for ESIS. Next slide. So we still have this problem. 1 in 4 strokes are recurrent. The highest recurrence risk really is within hours to days after the initial index TIA or stroke. And that was sort of something we've had to think about a lot in prevention trials with stroke. You get the most bang for your buck early, but in trials like Arcadia, the median time for enrollment was over 50 days. So we need to really push the enrollment time earlier. Next slide. And we know this pretty well from the CHANCE and POINT trials, which you guys are probably also familiar with, where we used short-term dual antiplatelet therapy in the first 12 to 24 hours after an initial high-risk TIA or minor stroke to look at and ultimately successfully reduce recurrent stroke from happening in non-cardioembolic strokes. And if you look at the interventional arm that did better with clopidogrel and aspirin, these patients actually still had pretty high rates of strokes occurring after their index event. In point, it was over 5%, and in chance, it was over 8 to 9%. So next slide. We really, for the future of stroke prevention, we're thinking, how do we do a trial that's going to be earlier on? And then I want to add the point that in the discussion point about ESIS, remember I said the research definition was atherosclerosis less than 50%. But the truth is that those patients still very well may have atherosclerosis contributing to the cause of their stroke. 30% plaque could still be breaking off and leading to issues. And then there's another concept that was introduced in part by the COMPASS and Voyager trials for CAD and PAD, but can we actually use a combination approach of antiplatelet and anticoagulant together? For so long in stroke, it's been either or, but can we use the combination and therefore address multiple etiologies or even histologies of a clot? These clots are often chronic clots that are acutely breaking off. Is there benefit from having anticoagulation and antiplatelet together? We've been wary of that in stroke because of the high rates of bleeding, but with novel agents that might have low risk of bleeding, this poses a new opportunity. Next slide. So can we add anticoagulation to antiplatelets immediately after an index ischemic stroke to reduce recurrence without bleeding? That's really our aim. Next slide. And so you kind of heard about these phase 2 trials with factor 11A inhibitors that are starting to pave the way to answer this question. We participated in axiomatic SSP here at Stanford, and we were able to enroll patients within 48 hours in this high-risk period. And although the trials didn't meet their efficacy endpoints, nor were they really trial powered to do that, they did demonstrate, importantly, that there wasn't any increased bleeding risk between the novel factor 11A inhibitor compared to the standard of care dual or single antiplatelet therapy that was used. And Pacific Stroke looked at asundexian and Axiomatic looked at milvexian. And I think the main point is that it helped do the dose finding for now the phase 3 trials that are coming. So asundexian will be doing a phase 3 trial called Oceanic Stroke, and we're using milvexian 25 milligrams BID for the phase 3 trial Librexia Stroke. Next slide. So I'm really excited to be leading this trial at Stanford. It's going to be 15,000 patients globally. These are going to be adults over 40 years of age with mild stroke as defined by the NIH stroke scale less than or equal to 7, or a high-risk TIA as defined by the ABCD squared score greater than or equal to 6. There's not going to be any major limitations to enrollment, except that the patient shouldn't already have a clear indication for anticoagulation like atrial fibrillation, or an obvious sort of other rare cause of stroke that's pre-identified, endocarditis, a dissection, et cetera. These patients will be enrolled within 24 to 48 hours. Actually, halfway through the study, they'll probably pull it back to only within 24 hours. So it's a pretty acute study for us. And the patients are allowed to be on dual antiplatelet therapy or single antiplatelet therapy as might be standard of care per point or chance. These patients will be followed up like any good prevention study over years. And the final duration will be event-based. And we'll be looking at superiority of milvexian over aspirin in time to first occurrence of ischemic stroke and of obviously bleeding profiles for safety. So thanks so much. I'm really excited to be partnering with everyone on this. And next we'll go to Dr. Kim to talk about Librexia ACS. Thanks.
Thanks, Dr. Vora. And so I'm going to just briefly talk about the role of anticoagulation in acute coronary syndrome. And we can sort of see where the Librexia program might fit in to the sort of unmet need currently for ACS. So recurrent MI or ACS is basically a leading cause of mortality and morbidity in the US and globally. And in the US, there's still about 800,000 MI events per year. And patients who actually survive an MI are at a higher risk for further coronary events, such that actually about 25%, just like stroke, of the myocardial infarction events are recurrent. And when you have when you have an MI event, your future life expectancy also is approximately 1.5 times lower in patients who have experienced MI compared to individuals with no history of cardiovascular disease. And so when you have an ACS event, and even if you're on dual antiplatelet therapy or the current cutting-edge medications, your risk remains quite high, especially at the early time points within the 30 days to 90 days. And going out to 1 year, basically about 12% of patients have a recurrent cardiovascular event within 1 year of index AMI. And this is based on large clinical trials where all patients were treated with either ticagrelor or clopidogrel. And so despite dual antiplatelet therapy, there still remains a residual risk for these recurrent cardiovascular events. And when you have a recurrent myocardial infarction events, your mortality is much higher compared to having your first event. And this is in about 5,000 patient cohort from Israel, showing that patients who have a recurrent ST elevation MI have a much higher 1-year mortality risk as well. And furthermore, if in patients with multi-vessel disease, multi-vessel coronary artery disease, if you have additional risk factors such as age greater than 65 years old, peripheral arterial disease, or a prior non-fatal MI, your risk is much higher. And in this trial, looking at primary care data from UK, basically there was about a 3-fold increase in your risk for major adverse cardiovascular events going out to 1 year if you had 2 additional risk factors on top of multi-vessel disease, putting your risk at 1 year at a whopping 50% of having some type of cardiovascular event going out if you have multiple risk factors following initial MI. So next slide, please. So despite modern pharmacotherapy, as well as newer generation devices, such as the drug-eluting stents and the imaging-guided PCI, there still remains a high rate of recurrent MI that persists and are associated with higher mortality. And so this begs kind of a natural question, or how do we reduce this residual risk? And just like with a stroke, basically the question was, does anticoagulation in addition to antiplatelet therapy protect against recurrent cardiovascular events? So multiple studies were done to address this question, and both in the post-ACS setting as well as in the stable coronary artery disease setting. The Atlas ACS series of trials, especially the Atlas ACS2 TIMI-51 trial, which was a large phase 3 trial looking at about 16,000 patients with recent ACS within 7 days. And this is a trial basically adding a thrombin inhibitor, or rivaroxaban, which is a factor Xa inhibitor, at a low dose in addition to dual antiplatelet therapy. And this showed that the primary efficacy of cardiovascular death, MI, and stroke had a significant reduction with a hazard ratio of 0.84 and a p-value of that met the significance as well, with the number needed to treat around 50. And then the COMPASS trial, which was a trial that looked at the role of low-dose rivaroxaban in addition to aspirin, compared to aspirin alone or rivaroxaban alone. And this was done on patients, about 30,000 patients with stable coronary disease. And this also showed that there was a significant reduction in primary outcome of cardiovascular death, MI, and stroke. Despite all these studies showing that there was a reduction in cardiovascular mortality and events, they all were basically had a safety outcome that balanced the primary efficacy outcome. And basically with this, even with this very low dose of rivaroxaban at 2.5 milligram BID post-ACS, there was a significant increase in the major bleeding. As you can see on the bottom there, there's 1.8% versus 0.6% compared to placebo. And this is also the case for the COMPASS trial. And then next slide, please, Marco. And so this is another trial looking at thrombin receptor antagonism with Paxar. And again, the major take-home point was that there was, again, a reduction in the primary efficacy outcome of reduction in cardiovascular death, MI, and stroke at the price of increased major bleeding as well. So so within the first 30 days of ACS, there is a high burden of a sort of recurrent event. And so a benefit-intensive antithrombotic therapy generally outweighs the risk of bleeding. However, after 30 days, I think the benefit really dissipates, and it really favors a therapeutic approach that balances the risk of bleeding and the risk of thrombotic events. And really the goal would be to try to find the sweet spot that reduces the risk of high-risk ischemic events as well as the bleeding events. And so just to summarize, there is an unmet medical need at this time because patients post-ACS, despite definitive therapy, still have a significant risk of cardiovascular death, recurrent MI, and stroke, which is high initially, then lessened, but never really goes away despite dual antiplatelet therapy. Factor Xa inhibitors lead to an increase in bleeding on top of dual antiplatelet therapy. And currently, even though rivaroxaban is actually approved for chronic CAD on top of aspirin alone, or in biomarker-positive ACS patients in Europe, the use remains very low because of physician concerns about bleeding. And so really finding a novel anticoagulant with a positive benefit-risk profile in post-ACS patients is something would be very clinically meaningful. Next slide, please. And I won't go into details. I think Mark already talked about the role of factor 11 inhibition, but based upon the epidemiologic data, the phase 2 data, the factor 11 inhibition may actually fit that sweet spot where it reduces ischemic events and not significantly increase major bleeding. Next slide, please. So the Librexia ACS trial, which is the other arm of the 3 trials, will test if factor 11 inhibition can reduce ischemic events without increasing major bleeding post-ACS. And the hypothesis is that treatment with milvexian, in addition to antiplatelet therapy, is superior to treatment with placebo in addition to antiplatelet therapy for reducing risk of MACE. And the primary efficacy objective, primary outcome we're looking at is whether milvexian is superior to placebo in addition to standard of care in reducing the risk of MACE, which include the composite of cardiovascular death, MI, ischemic stroke, and there are some other secondary objectives. And then primary safety objectives, go to the next slide, please, is looking at the rate of bleeding classified in the bar categories 3C and 5, which include intracranial hemorrhage, fatal bleeding as a composite after treatment with milvexian relative to placebo. And so the study design is basically we're looking for anyone with acute coronary syndrome that's biomarker positive, as well as but additionally have 2 risk factors to enrich the population, and these include age greater than 65, diabetes, known multivessel disease, as well as high-risk features in angiogram that are done post-ACS. And we want to try to get to these patients early, as we see that the much of the risk is in the early phase following post-ACS. So within 7 days of presenting with ACS is our time window to try to get to these patients. And we will randomize 1-to-1, either to milvexian 25 BID, which is the same dose as the stroke trial, or to placebo in addition to a pre-specified dual antiplatelet or single antiplatelet therapy. And the follow-up will be a sort of variable depending on what the sort of global recruitment is like. The goal is to get to 16,000 patients globally, and currently we're at about 2,000 patients globally. Next slide, please. And the antiplatelet strategy will be pre-specified by the investigator based on the sort of duration. So you can either plan to have DAPT therapy for greater than 90 days with or without de-escalation. You can plan to de-escalate at 90 days to a single antiplatelet therapy, or you can plan to start with single antiplatelet therapy only, and then you will be blinded and randomized at that point. Next slide, please. So we are currently recruiting. So if you have any patients that have ACS in your service, please let us know. I think it takes a village to get these trials up and running. So I just want to thank the study team, and we're looking to answer a very important question here from this study trial. So let me just give the podium back to Marco. So thank you, Marco.
Great, thanks a lot, Brian. So we're going to switch gears a little bit and talk about some additional strategies in stroke prophylaxis. And here I'm going to focus a little bit more on atrial fibrillation. So one of the best strategies to reduce the complications of anticoagulants is to not have to use them. And so we know that over 90% of the embolic strokes that are related to atrial fibrillation are due to clot formation in the left atrial appendage. And you can see sort of an echo still image here on the top left. One of the strategies that has been developed is to essentially occlude the left atrial appendage so that this clot does not form to begin with. The only FDA cleared device to do this is called the Watchman device. It's a little basket that gets placed sort of transeptally into the left atrium and then into the left atrial appendage. It gets deployed in the appendage, and then over time, there is endothelialization over the basket. So this has been studied and compared to warfarin therapy, and in a trial done in 2014, it was shown to be non-inferior. The issue, however, of course, is that as with any procedure, there are risks of complications. And the risk of a major complication when doing this is about 2 to 3%. And it includes things like embolization of the little basket. So in the most recent guidelines that came out just in December of last year, what is recommended now as a Class 2A indication is that if a patient is not capable of taking oral anticoagulant therapies, but is at high risk for stroke and needs some protection, then the recommendation, again, a Class 2A, is that a left atrial occlusion device be used. And this is in part based on sort of non-randomized data. So there was this study called Evolution, which was a prospective study that compared Watchman use to historical data. And as you can imagine, compared to nothing, the use of Watchman results in lower rates of a stroke and so because of this, if you have a patient who just is at higher risk of stroke but is not a good candidate for anticoagulation, then this is a good alternative. However, when thinking about whether or not a patient should, who is a candidate for an oral anticoagulant, should have a Watchman placed instead, I think one has to consider some of the risks involved. And there certainly will be patients who have a strong preference to come off anticoagulation. And in the guidelines, there's now a Class 2B indication for these patients. There was a non-inferiority randomized trial showing non-inferiority of the Watchman versus DOACs. So there is that possibility that these patients can receive a Watchman instead of staying on lifelong anticoagulant therapies. But again, you have to factor in some of the risks and have that sort of conversation with the patient. Now, what's slightly different is what we do in the context of surgical cases. So, if a patient with atrial fibrillation is going to have a heart surgery, so CABG or valvular surgery, then what we've learned is that by either ligating or simply cutting and sewing the left atrial appendage, there can be a significant stroke reduction. But I think the important thing to keep in mind is that these patients must remain on anticoagulant therapies. What the surgeons will do often is either cut or staple or clip the left atrial appendage. But what happens is that there can still be a little stump that's left, and in that little stump, clot can form. In fact, earlier this week we had a patient post surgery who had a ligation of the left atrial appendage go into atrial fibrillation, and we wanted to cardiovert, but before doing that, we did a TE, and sure enough, he had a little clot in that stump, so we were not able to cardiovert them. So these patients certainly still are at risk of forming clots, and so must remain on anticoagulation. And in the randomized trials, so LAOS 3, which was published in 2021, showed that there is a benefit to doing this in patients going for surgery. However, this trial was done in the setting of anticoagulation after occlusion of the atrial appendage. Now, there are some techniques that can be used in the operating room to sort of optimize the occlusion and minimize that sort of stump formation, but still not perfect. In patients who want to come off of the anticoagulant after surgical removal, there's still no good data showing that that's safe. So at the moment, there's a Class 2B indication for coming off anticoagulation in those patients. But again, I think the data is just not sufficiently supportive of that strategy. So the other idea is that perhaps there's a way of sort of minimizing the use of oral anticoagulants in patients with atrial fibrillation. And there's certainly patients who have a relatively low burden of atrial fibrillation and maybe at the lower end of the spectrum of risk. So they might be high enough risk to be on lifelong anticoagulation, but might lie on the lower end of that risk spectrum. And so these group of patients might be good candidates of what we would call pill-in-the-pocket oral anticoagulation. The idea being that why take oral anticoagulants all the time if the atrial fibrillation events that they're having are quite rare, and perhaps we can only anticoagulate immediately after an atrial fibrillation event for stroke prophylaxis for a fixed amount of time. And this would essentially minimize their exposure long-term to oral anticoagulations, but maintain stroke prevention. And we know from studies that have been done that there is this sort of interaction between sort of amount of time in atrial fibrillation and stroke risk, or CHA2DS2-VASc score. And so there may be, again, a group of patients with a combination of low burden and relatively low stroke risk that might be good candidates for this strategy. In this study that was done recently, what was found, and this was a study that was done in over 800 patients who already had some kind of device, either a pacemaker or an ICD, and then who also had a stroke. And an analysis was made to look at the temporal relationship between those strokes and atrial fibrillation in that sort of case crossover study design. What was found was that the vast majority of the strokes happened within 30 days of onset. And these were patients who were having relatively prolonged episodes, so at least 5 hours of atrial fibrillation. But the strokes mostly occurred within that 30-day period. But not only that, they occurred much more likely in the first 5 days compared to the rest of that 30-day period. So that initial time right after onset of atrial fibrillation is when you want to anticoagulate, but then the risk of stroke sort of trails off afterwards. So the next question is, well, if we're going to use this strategy, it's one thing if you have a patient with an implanted device where you can somehow monitor in real time and alert you to episodes of atrial fibrillation, but how can we do this in patients who do not have these implanted devices? And here's where I think we can use some novel technologies. So, a few years ago, we led this study, the Apple Heart study, where we investigated the use of a smartwatch in order to detect atrial fibrillation. And this study was for sort of primary screening or detection of atrial fibrillation. And it uses the LED and the light sensor on the back of the watch to measure the pulse. And the algorithm that's used is that in the background, the pulse is being measured, and if there's enough irregularity, pulse gets measured a little bit more more frequently, and if there are enough measurements of irregularity, then that might be consistent with atrial fibrillation, and a user can be notified that they may have atrial fibrillation. And these users were asked to call a study doctor, and we ended up sending them ECG patch monitors, and found that about 30% of the people who had these irregularities ended up having atrial fibrillation detected on patch monitoring. And if they were wearing the watch and the patch monitor at the same time, we found that the positive predictive value of these irregular pulse notifications was on the order of about 86%. Many of the positive notifications that were not atrial fibrillation were actually things like frequent PACs and frequent PVCs and things like that. So this opens up the possibility of this pill-in-the-pocket anticoagulation strategy. So we know that AF and stroke are temporally related. We know that it takes a few hours of AFib for the stroke risk to increase. And we also know that DOACs act pretty quickly. And we've seen that in theory, this could be done with implantable devices. But the question that we had was whether or not we could use a wearable device to detect episodes of atrial fibrillation in order to use this pill-in-the-pocket strategy. And so the idea is that a patient with atrial fibrillation who has relatively low burden can come off of their anticoagulant, and only when they are alerted that they have an episode of atrial fibrillation would they then start taking the anticoagulant. They would take it for about 30 days, and then we know that the stroke risk after that, if they're back in sinus rhythm, essentially is minimized. And so right now we are conducting this study called REACT Atrial Fibrillation. It's an NIH-sponsored study. Enrollment's already underway. Our goal is to recruit about 5,000 participants into this study. And these are going to be participants who are relatively low burden of atrial fibrillation, CHA2DS2-VASc score about 1 to 4. We might actually increase that to 5. And importantly, are already on lifetime use of DOAC therapy. And so this will be a randomized trial comparing this pill-in-the-pocket strategy using the smartwatch to just standard of care, which is just continuation of their DOAC throughout the duration of the study. And we're looking for non-inferiority. So we're looking at primary endpoints of ischemic stroke, systemic embolism, and all-cause mortality. But the hope is that if we can have these patients not have to use their anticoagulant for prolonged periods of time, that their risk of bleeding in the long term will be diminished. And so we're looking for superiority when looking at our secondary endpoint of major bleeding. The study, we started enrolling about a few months ago, and we are following these patients for up to about 5 years. So a few of the inclusion criteria to go through. So again, these are patients with non-permanent AF and infrequent AF. We talked about the CHA2DS2-VASc score, so relatively low end of the spectrum, but no, we're not including patients with with prior stroke or TIA. And then again, importantly, they do have to be on a DOAC at the time of screening and willing to stay on the DOAC throughout the duration of the study. They do have to own an iPhone. We are providing study watches to them, and they have to be willing to wear them. And we have a pretty extensive sort of safety mechanism in place. We're actually monitoring these patients in real time so that we're making sure that they are wearing the watch, that they are getting pulse measurements measured, and that they are receiving their notifications and responding to their notifications. And so again, there is this sort of safety concern about an increase in stroke risk, of course, by coming off the anticoagulant. But we have a pretty, I think, robust system in place to make sure that the patients are actually following the protocol. And as I mentioned before, because we want relatively low burden patients, if a patient has had more than an hour per month of atrial fibrillation over the last 3 months, then they wouldn't be a candidate for this study. We're also excluding patients who had frequent PACs or PVCs because, again, this confuses the pulse algorithm. And by the way, we are using a modified algorithm, not the algorithm that was used in the Apple Heart study, the one that you have on your watches now, but rather a modified version that's a little bit more sensitive to events. And we're excluding patients with ICDs or pacemakers, patients who've had atrial flutter, because atrial flutter can be regular. So unless they've been ablated, they should be excluded. And of course, patients who have other indications for anticoagulation. I think there are several implications to this study. So obviously, the thing that we're all excited about and the patients are excited about is the possibility of coming off anticoagulation. This would reduce bleeding, costs, improve quality of life, and so on. And I think it has other implications. There may be a change in indications for the control. So a patient who may be not very symptomatic, who has atrial fibrillation, might want to undergo aggressive rhythm control in order to come off anticoagulation and using a strategy such as this pill in the pocket anticoagulation. And I think what's also very exciting is that we're going now from the ability to detect disease, as we did with the Apple Heart study, now to the actual management of disease with the use of these smart technologies to guide therapy. So we're actively recruiting. We are the clinical coordinating center for this study. Rod Passman is the overall PI at Northwestern. Our site PI will be Alex Perino, and our research coordinator, Alyssa Hernandez, and their contact information is right here. So please, if you have any patients who want to come off anticoagulation and are interested in this strategy, then please let one of us know. All right, so with that, I'll close and we'll open things up to questions.
Thank you, Dr. Perez, Dr. Vora, Dr. Kim. So what I just saw was potentially 4 different grand round topics, somehow beautifully done in under 45 minutes and beautifully presented. Thank you so much for that. And clearly, each one of them is such a big deal to change practice to so many patients. We have a number of questions coming through. I'm going to try to get through them. I know, Dr. Kim, you might be answering this one to Dr. Friday. I'm going to just ask this first. How do you think increased use of SGLT2 inhibitors will affect outcomes in planned studies, so potentially impact all 3 of those Librexia studies? And I don't know if probably any of you can comment on that, Dr. Perez.
I'm sorry, Brian, do you want to take this one?
Yeah, I would just so there are some animal studies that's showing SGLT2 inhibitors can actually reduce thrombin generation as well as platelet reactivity. So I think overall there will be a reduction in the risk, I guess, following ACS, but I'm not sure how significant that impact would be, and I think we will still be able to capture, hopefully, impact reduce the risk of recurrent MI with additional anticoagulation.
For stroke, I'll add, I think it's great. I think we need to be optimizing prevention in all arms and really looking in the real world model of aggressive medical prevention. Can we still do a good job? For stroke, since we were really doing this to start acutely, and I told you that the risk of recurrence is really in the acute period, I don't think it should impact us in any big way, but I hope and wish that patients will be as maximally controlled on prevention and then do this trial to look for the added benefit.
Excellent. A question by Dr. Wang. What is the intraoperative plus perioperative complication risk for device installation and for surgical left atrial appendage occlusion? What increased arrhythmia or after structural damage from surgical scar formation? Any data around that?
Yeah, so for the Watchman, the risk of a major complication is about 2 to 3%. So the risks are, for example, sort of basket embolization, perforation, and tamponade, and risks like that. But the risk of a major complication like that is about 2 or 3%. So and there are strategies now to kind of minimize, help minimize that risk further, and with experience, those risks can come down, but there's still real risks. For surgical occlusion, and that, again, that's done mostly with cut and sew, but there are also devices available such as clips. The concern was mostly just added time on the pump, but these things can be done now rather quickly. They do need to be optimized with TEE and to minimize the stump and so on. That the added risk of doing something like that, surgical risk, is minimal. And now the pump time is not that much longer. So I think that the risks there are the added risks are pretty minimal.
Yeah, I'll just add that in addition to the Watchman, like Flex, the modern device, there's also the Amulet device that's FDA cleared, and I believe they are quoting even a little bit lower rates of, I think someone asked about severe peri-device leak and things like that, but I defer to the experts, of course, who are doing these device placements.
Dr. Vora, you were messaging back with Dr. Friday in the chat. I don't think participants could see that. Do you mind if I just ask you to bring that up at the
Yeah. So thanks, Dr. Friday, for your question about how LAAO can benefit patients that are at high bleeding risks in neurology, like those with cerebral amyloid angiopathy. So just for a little bit of background, cerebral amyloid angiopathy is a condition that is when the beta amyloid protein that we think about in Alzheimer's is actually deposited in the blood vessels of the brain rather than in the brain tissue itself, and can lead to destabilization and loss of integrity of the blood vessel and increased rates of bleeding. It's also associated with cognitive impairments, seizures, and other transient neurological symptoms. So these patients are at high risk for bleeding, and we are really worried about anticoagulating these patients and even putting them on dual antiplatelet therapy. So while in theory, an alternate to anticoagulation like left atrial appendage occlusion initially seems attractive, the issue is to prevent device leak and other complications and good endothelialization. These patients still need to be on some sort of short-term antithrombotic strategy after placement. So whether it's 6 weeks of dual antiplatelet therapy or some kind of DOAC or other anticoagulation, that still poses a concern for these patients. And we are happy to see all of these patients in vascular neurology clinic to sort of risk stratify them to the procedure. We work really closely with the arrhythmia and electrophysiology group on this. And I think that for the most part, we haven't been sending all of these patients unless they're already on anticoagulation and then they're sort of incidentally discovered to be having this CAA as a possibility based on some other brain MRI that they got. And then we feel a little bit more comfortable that they are tolerating the blood thinner, but long-term may continue to accumulate these microbleeds, and we want to get them off of it. So that's sort of a safe mechanism. But if they're already having intracranial hemorrhage and tons of microbleeds, or what we call superficial siderosis, so sort of leptomeningeal deposition of amyloid, we aren't going to send those patients for LAAO. Thanks for the question.
Dr. Perez, you mentioned that the REACT-AFib study, this is a new paradigm. We're using the watches perhaps now to guide treatment, perhaps in real time in the future, which is amazing. So a couple of questions. Another one just popped up very similar and adds to it with Dr. Stockdale and Dr. Carr. Dr. Stockdale asked in the RAC study, how does it work when people are sleeping at night? I'm assuming they're wearing their watch.
Yeah.
Dr. Carr also just mentions, what kind of watch are they getting? I'm assuming it's the Apple iWatch, and are they required to wear it while asleep?
Yeah. Yeah, so important question. So one of the concerns, of course, is, if they're not wearing their watch, perhaps while they're asleep, could they develop an event, and then could a clot form and then have stroke, a systemic embolism because of that. The data that sort of supports the strategy that we're taking comes from studies that have looked at patients with pacemakers, ICDs, who have bouts of atrial fibrillation. And what we know is that we don't see really an increase or significant increase in stroke risk until the participants have been in atrial fibrillation for several hours, and usually about 6 or more hours before we start to see an increase in stroke risk. So these shorter events, that last, just under an hour or just a few hours, aren't significantly associated with a big increase in stroke. And we think that, it just takes a little bit of time for this clot to form and then ultimately embolize. So we think there's some there's low risk in sort of missing an event, an AFib event that might last only a few hours. They are getting an Apple Watch for this study, and so that's the device that we're using. But we're using a modified algorithm to the one that's existing for screening for atrial fibrillation.
Dr. Kim, you mentioned about the use of low-dose rivaroxaban. I've seen patients on it. Use of that's approved in the EU. Is it approved in the US, or is part of the study the opportunity to have a low-dose anticoagulation approved that we don't have yet?
That's right. So the low-dose anticoagulation is not currently approved in the US, and I think this is the chance, I think, to try to get that incorporated into our, I guess, armamentarium of things that we can give to patients following ACS.
Excellent. And just generally speaking, Dr. Perez, you mentioned at the beginning, patients with congenital defect in factor 11, they tend to have low risk of bleeding, but low risk of clots. So the whole theory behind this that applies to all these studies is that this drug could, and hopefully is, really superior, safer, maybe even equally or perhaps more effective in all of these indications at the end of the day.
Yeah, that's, I think, the really exciting feature. And that's why also I think it's not only important to show non-inferiority, but also superiority in terms of bleeding risk. And I think that, I mean, if we see a better bleeding profile with a new generation of drugs, I think we'll have more patients willing to take them.
Dr. Friday mentions great ground rounds, very interesting. Thank you so much for this. Probably a perfect, Dr. Golden asked, and this is a perfect question time. How do we get people into your program? We'll send a follow-up email. Would you like us to include a link or anything with the recording of this? We're happy to.
That'd be fantastic. Yeah, if we could send out a sort of a message on how to refer patients for all of these studies, that would be really, really exciting. Yeah.
Wonderful. So we can list our community listening right now that they've learned more about this. Doctors, thank you so much for this. This is amazing. This is, each one of these arms are an amazingly impactful study in a huge population. So we have 4 major studies you presented just now in a short period of time. That was amazing. In the future, we have multiple presenters. Usually we go way over time. This is the gold standard now in the future. Thank you for all the great work you did and how highly efficient it was. I hope we can invite you back in the future to present any updates. And again, it could be as one group or multiple grand rounds, perhaps, whatever you'd like. But thank you so much for this amazing work, and we're looking forward to hearing the future of it.
Great. Well, thanks for having us.
Thanks everyone.
Thank you.
Have a great day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.